I think we'll go ahead and get started. For this session, because we had two workshops, we wanted to try to cull out the important information from each of the workshops and present it to you so that if you didn't have a chance, you wouldn't have had a chance to go to both of them. We also want to say that this will be probably on our websites, and we actually did videotape the clinical session, so if it's looking good enough, you might be able to access that as well. So we had a workshop on clinical practice as well as a workshop on the research practice. And so we're going to ask, I'm first going to ask Dr. Saypol, who has co-moderated the session. Dr. Saypol is Artistic Director of Theater Delta, which is an interactive theater ensemble based in Chapel Hill, North Carolina, that promotes social change in communities nationally and internationally, working with doctor-patient communication being a major area of his focus. He's also a visiting professor of theater at Loyola University in New Orleans. Dr. Saypol and our group at UNC have been working for over a year developing interactive theater modules for our fellows and decided to transport that into a multicultural context for this meeting. Ben?
So thank you very much for having me and including me in your conference. So it was cross-cultural communication workshop here at the conference, and here we have our moderators and some of the members of the audience. Do I have control of this?
Yeah.
Oh, great. And do I just do right here?
No, just push the button.
Okay. Ah, wonderful. Great. So there is Dr. Drossman, and there was I, and we were the moderators, the facilitators of the session. And then again, this was an interactive theater workshop. So we had a cast of characters. And if you were in the workshop, you know that the performances were Oscar-worthy. So the Oscars in Vignette 1 went to Dr. Drossman, played the doctor, and Dr. Ademola Aderaju played the patient. Vignette 2, the Mexican patient, our doctor was Lin Chang, and our patient was Carolina Olano. And in our third vignette, we had a Russian patient played by the doctor was Lin Chang, and the patient was Albina Halpert. Goals. Goal. No. So, and just real quick, these two goals are in honor of Dr. Aderaju, who's from Nigeria and thinks Nigeria is the best football team. And down below we have Uruguay, which Carolina thinks is the best football team. But our goals for the workshop were to highlight cultural differences in communication in a medical setting, using interactive theater and facilitated discussion. I'll talk about that in a sec. And then to apply strategies to obtain more effective interactions consistent with the patient's illness schema or explanatory model. Here was the case history, kind of a generic IBS case, 36 years old, 10-year history of mid to lower generalized abdominal cramp-like pain made worse after eating. Frequent stools with some relief of the pain after defecation, abdominal bloating and occasional nausea, and the symptoms occurred several times a month, but without loss of ability to work or engage in usual activities. That was kind of the general history. But in the last 6 months, symptoms became more acute. All right, there were severe episodes of abdominal pain and watery diarrhea with fever and chills. There were several episodes of urge incontinence. Patient had cut back on eating and had lost 5 kilograms. The patient saw the family physician 2 weeks ago, no abnormalities. Blood work included CBC, sedimentation rates, serum TTG, electrolytes, and liver chemistries were normal. Stool culture for bacterial infection and for ova and parasites were negative. A barium enema and CT scan were normal. Experiencing an inability to carry on usual work and social activities, limited activities outside of the home. So again, this was specifically an interactive theater format, whereas typically we go, we watch a performance, we give a round of applause and go home. Here the audience actually gets to interact with the characters and have a dialogue. So we presented each vignette, which again was a condensed medical interview. Then we facilitated an audience discussion. What did you notice in the vignette? And we're specifically looking at cultural characteristics and communication. After that, we would actually check in with the patient. Just for those of you who weren't there, the actor would remain in role. And we said, how was your experience with the doctor? And the patient could kind of express kind of degrees of disappointment with the fact that the doctor did not get them. Then we would facilitate another discussion with the audience. How can the doctor improve, right? What strategies, what techniques? And then as the suggestions came in, we would replay the vignette with the doctor taking the suggestions. Vignette 1, the Nigerian patient. This is what the audience brought up. They noticed his strong national identity. When the doctor said, "Are you African?" he goes, "No, I am Nigerian." And that was a big deal to him. This particular patient was hesitant to share his symptoms of bowel dysfunction. I feel a heaviness. Maybe didn't name it so much as pain. He would qualify and say maybe when asked about urge incontinence, even though it was there, probably not. He talked about being caught between his mother and his fiancée, and the mother also wanted him to seek religious remedy. This particular patient abdicated full responsibility to the doctor. When the doctor wanted to include him in his in strategies for care, he resisted. And he had a strong negative reaction to antidepressants. "I'm not depressed," he said. Vignette 2, the Mexican patient, some cultural characteristics that came up. The female patient called the female physician señorita, and the doctor had a bit of a reaction to that. There was some unique terminology. Bloating was not like a word in the vocabulary. Everything was inflamada, and she stood up to demonstrate it. She thought that she must have an amoeba, a parasite, as that's kind of one of the common thoughts in Mexican culture. There was a fear of cancer and a big relief when she learned that the tests were negative. And finally, she had been to a curandero, which is a traditional folk healer, like a shaman or chaman. And also, similar to the other case, a negative reaction to antidepressants. "No soy loca, I'm not crazy." Finally, the Russian patient, some cultural characteristics. A very energized verbal communication style. Now, there was a tendency for this patient to interrupt, but it was not interrupting out of disrespect. Even though maybe on its surface the doctor might have perceived it as argumentative, it was not meant to be. She was trying to be helpful and trying to add information for care. There was a strong desire for, she had brought a medication over from Russia, and she really, really wanted that medication from this doctor, but it was not available. And there was some wariness around American medicine, specifically around testing, that there's this belief that Americans order too many tests. So when the idea of a colonoscopy came up, there was resistance. "Is that really necessary?" she asked. Finally, just some themes and strategies that we took out overall. I apologize for the amount of text, but it's going to be on the computer as well, so I wanted to put it. But the overall themes focused on the doctor increasing their active listening skills. Simply listening and allowing the patient to be heard can be an extremely effective technique. Increasing empathy, that sense of empathy in the room that the doctor very much cares for the patient. This idea of yes and instead of yes but. So when you hear something, you don't go, "Yes, but," and follow with information. It's, "Yes, I hear you, and I would like to add." It can be very helpful. And just an overall theme that a few small changes in the medical interview can make a world of difference to the patient and the establishment of rapport. Finally, strategies, specifically around cross-cultural communication. Increased knowledge of characteristics of patients from other cultures, helps to know what might be coming. Manage physician emotions when differences trigger reactions. Avoid dismissing and diminishing the patient views and attitudes. And finally, increase awareness and exploration of psychosocial issues, specifically ones that arise from the patient's unique culture. There are a lot of resources on your memory key. We want to arm you with as much information as possible when dealing with these issues. And finally, I just want to tell you a little bit about the organization that my organization and Doug and I have been collaborating for the last year and a half. Theater Delta uses scripted improvisational theater to promote social change in communities around the globe. We believe that when people participate in creating drama on stage, they're more likely to explore and change personal attitudes and behaviors in their own lives. There's a little typo there, which I will fix before that goes up on the website. And We have a website, theaterdelta.com, and thank you so much for your time.
We don't have it built in, but we can allow a few minutes for a discussion or questions for Dr. Saypol, and then we'll go on to the second session. Any comments or questions? Here comes somebody.
I just wanted to say that interesting idea and way to do it. A few things that I think would be helpful to clinicians that are here, and that is that whenever you work with a cultural group that you don't know, it's probably a good idea to read something about that culture and inform yourself. It won't take the place of actually listening to a patient. But for example, you might find, like, there was nothing in here about body language, and it's really important. Like, for example, with a certain group of people from Vietnam, you would not want to show the bottom of your foot. If you were a doctor, you would not want to go like that, because that would be offensive to a Vietnamese patient. And there's all sorts of things like this that might help you not turn off the patient before you even start. Thanks.
Wonderful. Absolutely. Thank you so much for that. And yes, to kind of, if you know the patient is coming in advance and you know specifically what culture they're from, to kind of read and increase your knowledge around that culture. In the resources, there's also things like the cultural chat, the cultural health assessment tool that can also aid in that regard.
Very interesting talk, that, and it brings up a point in some research I'm doing, and that is asking experts, some of whom are in this room, whether they'd prefer a structured type interview or the narrative from the patient. And there seems to be quite a variety of responses and a huge sort of gulf between what different experts think. How do we bring that all together with all of these different foundations, and can we set a template, or do we just leave it to the individual clinician to get on with what they do best?
Great. So.
I think in many ways clinicians do what they do best, and they gravitate into certain areas. I think there are some generic qualities. Everybody who goes into medicine goes through history taking and physical diagnosis. So I think we're trying to create the generic template, which is, and I say generic because as we saw, it's listening actively, providing empathy when needed. I don't think that that's necessarily going to be related to structured or unstructured. I think it's something you would do anyway. So I think it'll, again, where you go from there is up to the individual.
One question. Did you develop any kind of instrument to evaluate the impact of your intervention with the fellows at UNC?
I'm sorry, can you just ask that question again? I didn't hear it.
Did you develop any kind of instruments to evaluate the impact of this kind of intervention with the fellows at UNC?
Great. Yes, we did. So Theater Delta does have a system of monitoring and evaluation. And at this point, it's kind of, we have an evaluation form that we pass out after every performance that initially we kind of want to see their reaction to the medium itself. Then we explore a little bit of attitude change, and then we explore a little bit of intended behavior change. And we've just kind of finished round one of our project that we did for his group of fellows and also for all of the second-year medical students at the University of North Carolina. And that data is coming in, is being entered into a spreadsheet, and it's looking very positive in terms of efficacy and impact. And we'll obviously publish a report for our funders and disseminate that as well. And as part of that grant as well, we videotaped the modules, and while they won't be shown in full, a condensed version will be available on the center's website, which is the UNC Center for Functional GI and Motility Disorder. Excellent question.
Can we use the system for self-support group of patients, just patients?
Great. So you're
so
asking
for education and to get involved in their own say, care of their own disease in a way?
Great. So it's a wonderful question. So the specific module we developed at UNC is geared towards doctors and the doctor-patient relationship. But absolutely, I think it could be used for patient advocacy. On the surface, I think that scene, we've created 2 scenes, could be used for that. But I think what I might prefer, if we go that route, is to kind of create a specific scene that shows the challenges that the patient faces, rather than focusing on the doctor. And then again, we use that same model of scripted scene. Then the audience gets to interact with and engage with the scene in a facilitated dialogue. But excellent idea.
Okay, thank you, Ben.
Great.
Thank you for coming.